So today I'm going to be talking about contraception, perimenopause, menopause, HRT, how it all fits in. Different background. This is one of my daughter's artworks. I'm down in London visiting her today. So anyway, there's lots to talk about and lots of questions. So thank you so much for your questions. And it's something I think about more and more. So just to go back really a little bit, during the perimenopause, that is the time when our hormone levels fluctuate and change, but we still have periods. And also, if we still have periods, we're still producing our own hormones. And as many of you know, the reason that we have periods is because we don't get pregnant. And that sounds a bit weird, but actually, evolutionary, women are designed to reproduce. That's actually, you could argue, our function, to become pregnant, get pregnant, and have babies. And then actually, we're actually supposed to expire and die after our reproductive age. And if you think in the Victorian times, the average age of the menopause was older. It was about 57. And the average age of death for women in the Victorian times was only a couple of years later, 59. And so advances in medicine have meant that, and also just lifestyle, all sorts of reasons, that we now live longer. And in the UK, our life expectancy is now our mid-80s. And actually, the average age of our menopause is younger. It's about 51 now. But in the perimenopause, this time of fluctuating hormones that occurs when our hormone levels are fluctuating, that's when we can start to experience menopausal symptoms. And often those symptoms can be worse than during the menopause. Now, we call them perimenopausal symptoms, but they're exactly the same as menopausal symptoms. So people sometimes get confused and think that perimenopause, you have to have a certain type or a certain number of symptoms, and it's different to the menopause, and it's not. But when we're thinking about contraception, what happens throughout our normal cycle is that our hormone levels start to build up the lining of the womb. And also in the middle of our cycle, we get this surge of hormones of estrogen and progesterone and testosterone, actually, which help the egg to be released, because we need the egg to be released, because then once we have an egg and there's sperm, obviously then they work together and start to form a fetus, an embryo, which then develops. But the fetus is only going to develop, or the embryo is only going to implant in the lining of the womb if the lining of the womb is thicker and cushioned. And that's important, and I'll explain why more in a minute. So you have to have a build-up of the lining of the womb. You have to have an egg, and then obviously the egg has to be fertilized by the sperm, and then that those cells need to implant into the lining of the womb, and then the pregnancy will start. Now, most cycles, women don't get pregnant, and so if there is no pregnancy, then what happens is hormone levels then drop in the second half of the cycle, the so-called luteal phase, and then the lining of the womb is shred. Now, that shredding of the lining of the womb is a period that we all have come to love or hate, depending on what you think about periods, but that is what happens actually. Obviously, what's happening is that if we became pregnant, we wouldn't have our periods. So being pregnant and not having periods, that's an indication that we need to do a pregnancy test, obviously, if we're not expecting our periods to stop. But in the perimenopause, that can last for 10 years or so. So for 10 years or so, women are going to often experience menopausal symptoms and have periods, and then think, oh my goodness, what am I going to do for contraception? And it's really important. There are lots of contraceptive choices that are available to women, a lot more than there used to be, but actually that can be quite bewildering and quite confusing for many people as well. As you know, I've spoken a lot in the past about hormone replacement therapy, hormone treatments, having the natural hormones back, estrogen, progesterone, testosterone. But these hormones are not contraceptives, usually. And I say usually because there's a whole problem with this, in that HRT isn't licensed as a contraception, and the contraceptives aren't licensed as HRT. And then it's like, well, what are we supposed to do as women if we need to have contraception and hormones? So this is where I'll just unravel some of the information, so then you can try and work things out yourselves a bit. So most types of contraception are hormonal. Obviously there's barrier methods and withdrawal methods, but I'm just going to be talking about hormonal contraception in this Instagram Live. So if you think most types of contraception contain a type of progesterone, and often if it's the combined oral contraceptive pill, then it will contain a type of estrogen as well. So if we start with the combined oral contraceptive pill, it contains a synthetic estrogen as a tablet, and it also contains a synthetic progesterone as a tablet, and they're combined together, hence it's called combined oral contraceptive. And traditionally they would have been taken for 3 out of 4 weeks. So women take the same dose, same type for 3 weeks, then have a week's break, and that's when they have a period. It's not the same as a natural period, it is just a withdrawal bleed. Because the body isn't stimulated by those hormones, then there's a shredding of the lining of the womb, and people often just get, it's like a response. So the womb doesn't build up in the same way. It's not the same as a proper shredding that occurs when our own hormones are doing that fluctuating. It's more like, because we haven't got the hormones, our body responds to that way. But now actually, or not now, but like the last 10, maybe 15 years, I've always recommended, and so have many other contraception experts, to have the contraceptive pill back to back, so people don't need a bleed. So actually for many women that's better, because they have the estrogen and progesterone every day, and they don't need to have this withdrawal bleed. Because the lining of the womb isn't building up, people sometimes think, oh, but I need a period. You don't need a period when you're on the combined oral contraceptive pill. And often people carry on taking it every day. Then if they start to have a bit of a breakthrough bleed, they might have a few days break, have more of a sort of period if you like, and then go back. Now there's pros and cons of that. One of the pros is that you're getting hormones all the time. One of the cons is that with the oral contraceptive, the combined oral contraceptive pill, it is synthetic. And we know increasingly that some women have side effects to the combined oral contraceptive pills, and also the progesterone-only pills, and I'll explain why in a minute. But there are different types of combined oral contraceptive pill, and they mainly contain different types of progestogens. So there are some progestogens that are affect the receptor slightly differently, so they can cause different side effects. Because they're all synthetic, they don't work in the natural way that our progesterone works. So some people find that they get more skin side effects, or they get more bloating side effects, or they might get more mood side effects, and it's all very different depending on the type usually of the progestogen. But there are different types of estrogen as well, and there are different doses of estrogen, and the types of combination oral contraceptive pill that I used to prescribe 25 years ago actually had a lot more estrogen in it than some of the ones that are available now. And so many people have to have 2 or 3 different types of contraception before they find one that suits them. And we usually say try and persevere for 3 months or so before you decide whether it suits you or not. But some people find that they really struggle to get on with the combined oral contraceptive pill. There can be a lot of side effects that people get. Now, another disadvantage of having synthetic hormones is that the tablet estrogen and also the synthetic progesterone can increase the risk of clot and stroke. Now, that risk is small, and for most women, their background risk of a clot or stroke is very, very small. So if you increase a small risk, it's still a small risk. But if people have got other risk factors, for example, they've had a history of a clot in the past, or they've got a family history of clot, or they've got a clotting disorder, then it might not be the best option to be on the combined oral contraceptive pill. People who suffer with migraine have a very small increased risk of stroke. It's only small increased, but you wouldn't necessarily always combine the small risk of a stroke with a migraine sufferer with taking the oral contraception. So often for women with migraine, we don't give the combined oral contraception as first choice. Another disadvantage, if you like, with the perimenopause is that women, when they have the combined oral contraception and they're taking it all the time, they don't have that week off. And often when women are having and taking it for 3 out of 4 weeks, in that week off is often when they start to experience symptoms. So women might say, look, I don't feel so bad when I'm on the contraceptive pill, but then in that week I start to get flushes, I get night sweats, I feel more tired, I feel more irritable. And that's an indication that they're not having their own hormones that are working once they've having that week off the contraceptive pill. Now, the other type of contraception that people often use are progesterone-only contraceptives. And it's a bit confusing, the terminology, because a lot of people call them progesterone. Now, many of you, if you've heard me before, I'm really a stickler for words. And progesterone is the natural progesterone we produce in our ovaries, in our brain, around our body. It's a very anti-inflammatory, it's a very calming hormone. It works as a neurotransmitter. It works and does a huge amount of very beneficial effects all around our body. Every single cell responds to progesterone. Now, the synthetic progestogens do not have the same effect. So when people call it progesterone-only pill, it should be the progestogen-only pill, because it's not pure progesterone, it's a synthetic progesterone. And then the other way that we give progesterone, or the synthetic progestogens, as contraception is either as an implant, so the rod that usually goes in the upper arm, or there's the Depo-Provera injection, which usually goes into the buttocks and lasts 11 or 12 weeks. That's the main way of having the progestogen systemically in the body. So when people have the implant, or when they have the injection, they don't have estrogen as well. It's just a synthetic progestogen, and it works all around the body. And what it does is it switches off the own hormone reproduction, so therefore an egg isn't produced. Very good, effective ways of sterilisation. And one of the good things, of course, is you don't have to remember to take a tablet every day. The progesterone, or the progestogen, we should be saying progestogen only pill, the POP, or the mini pill it's sometimes called, is taken once a day. Some of the older ones, you only had a 4-hour window to remember, and that's really difficult if you're busy or you have shift work or whatever. But there are other types where actually you've got a 12-hour window, which is better to remember. The other way of having contraception using synthetic progestogens is the contraceptive coils. So it depends on the country you live in, but classically the first one that was brought out, certainly in the UK, was the Mirena coil. Tiny little coil that just goes into the womb, and it releases a synthetic progestogen into the lining of the womb. Now, progestogens and progesterones work to thin the lining of the womb. If the lining of the womb is thin, then it doesn't build up. But also, the progestogen-only coils have a local effect, because obviously next to the womb are the ovaries. And often this the low dose of the hormone will actually affect the way ovaries work. And so for many women, it switches off their eggs being produced as well. So it has a double effect. So it switches off the eggs being produced, and it has a local effect on the womb. And like I've said before, if you became pregnant, those fertilized eggs have to implant on the lining of the womb. Now, if the lining of the womb is very, very thin and atrophic, then you're not going to be able to have an implantation, and a viable pregnancy isn't going to occur. So that's why often with the Mirena it's thought of as like a belt and braces contraception. It switches off ovulation, and it makes the lining of the womb sort of hostile for implantation of a fertilized egg. There are other types of coil. There's different ones that have got the same progestogen in as the Mirena coil, but they're just called differently, made by different drug companies. And there's a lower dose one as well, which is called, there's a couple, one called Jades and one called Kylena, and they don't last for as long. Now, they've changed the recommendations. The Kylena and the Jades were only licensed for 3 years. Now they've made them longer. I've read 4 and 5 years as well, actually. And then the Mirena was for 5 years, but often it can be used for longer as well, especially if women aren't getting any problems with it and they're not getting any bleeding. So there's lots of options. Now, one of the things that worries me, if you like, is that people having these synthetic hormones, I've just said it switches off the ovaries working. So therefore the ovaries aren't producing an egg, which is good if you don't want to have an egg, you don't want to have a baby. You know, without an egg, you can't become pregnant. But without an egg, without the ovaries working, you're switching off the ovaries producing estradiol, progesterone, testosterone. And I've already said many times before, and I'm sure I'll say many times again, the hormones estradiol, progesterone, testosterone are really important biologically active hormones that work in every cell all around our body, especially in our brains. I'm very interested in neuroanatomy, neurophysiology as well. And we've known for many, many years the importance of estradiol, progesterone, testosterone in our brains. Now, having those hormones aren't necessarily going to switch off the action of those hormones on our brain, especially the JDES and the Kylina because they work, and the Marina because they work locally. But the other hormones, so the contraceptive pills, the progesterone-only pills, the implants, the Depo-Provera, the injectable progestogen, do work all around the body. So they are going to switch off the way that our own hormones work. But they're also might, and they probably do. I'm hesitating because we haven't got good research, because no one's done really good research about the detrimental effects of these hormones, which really worries me actually. But actually, when you have a synthetic hormone in your body, it will actually block the receptors. It will sort of cover the receptors, if you like, in a very simplistic way. And if those receptors are covered and blocked, then even if you've got your own hormones around, they're not going to be able to link onto the receptor and have the same biological process occurring that would occur if you didn't have synthetic hormones on them. And you just need to look at the history of how the combined oral contraceptive pill was trialled and tested, initially in Papua New Guinea and then over here mainly on black women initially. And people had really awful side effects. They were vomiting, they had clots, they felt awful, their mood was terrible, no one listened to them for many months, even years. And then they realised the dose was high and they reduced the dose. We also know, and I know from lots of patients and friends as well, that many people have mood symptoms when they're on the contraceptive pills. Many people feel quite low, many people feel quite flat, they might feel quite lethargic, they have less energy. Like I said, they might have skin changes, they might have hair changes, they might have bloating. And this can be the detrimental effects of these hormones in our brain and our body. When people have the combined oral contraceptive pill, it increases something called your sex hormone binding globulin. And this then actually reduces the freely available testosterone we have in our body. So if we've got testosterone in our bodies, it's going to work less well if we've got the combined oral contraceptive pill. And actually, as a medical student, I was taught women taking the combined oral contraceptive pill might have less libido, but don't worry because their libido will be quite high anyway. But actually, with my inquisitive brain, I was thinking, well, why is that going to happen? Why would taking contraception reduce a woman's libido? Well, of course, it's because it's blocking the way it's blocking the way testosterone is working. We know testosterone is more than just sexual desire. It can actually often help with mood, energy, concentration, stamina. So a lot of people on the contraceptive pill find that their mood, energy, concentration, stamina reduces. And this is probably partly or wholly, who knows, because no studies have been done, related to blocking the available testosterone in the body. But the other thing is, all of these hormones that I've spoken about, the systemic ones, but even for many people, the coils as well, are stopping the way our ovaries are producing hormones. So it's actually giving people, if you like, a chemical menopause. And a lot of people, even sexual health doctors and contraception experts, don't really think about this, because it's really important, obviously, to think about having a good contraception. But actually, I worry about the systemic effects of these hormones. Many years ago now, there was some research coming out showing that women who had the Depo-Provera injection had an increase in incidence of osteoporosis. And I remember them thinking, why is that? And people were trying to say, oh, it's because a lot of women using the Depo-Provera were from lower socioeconomic classes. They didn't exercise as well. They didn't have maybe so much milk or calcium in their diets. But that still didn't make sense to me. And then actually when you think about it, it's because the estrogen is being blocked and the natural progesterone and testosterone. And we know those three hormones are very good at building our bone and keeping our bone very, very strong. So actually, if you're not having those hormones and the synthetic progesterone is blocking those receptors, then actually that's one of the reasons why people might have an increased incidence of osteoporosis when they're using these synthetic contraceptives. And actually we don't know, but is there an increased incidence of other diseases like heart disease as well, which we see obviously in menopause as well. Many people say, well, actually it doesn't matter because if you're only using contraception for a few years, once the contraception stops, the hormones will restart and everything will be fine. But many women now use contraception for a lot longer than they used to. Sometimes people can take contraception for a couple of decades, so 20 years. 20 years of suppressing hormones is likely to have some effects on the majority of us, whether it's side effects or longer term health effects. And this is where, as individuals, we really need to know this, and then it can help guide which contraception we want. I've already said there are different types of combined oral contraceptive pill, and there are ones that are more body identical. In the UK, there's one called Zoli, which actually contains a more natural estrogen and a more natural progesterone. It's more expensive than a lot of the oral contraceptives like microgynon, which has been around for donkey's years. But actually, a lot of people find they don't have side effects with it, and it's likely to be safer as well. It's a real shame because a lot of women really battle to get this sort of the nicer, the safer oral contraceptives, the ones with less side effects as well. And I really hope that it will change, because actually, if women are on the more body identical type of contraceptive pill from the start, they're less likely to go back and forth for consultations. They're more likely to be more productive, less likely to have side effects. So in the longer term, actually, it probably will be cost effective. The other thing to think about is, I've already said, like having the implant or the progesterone only, the Depo-Provera injection, or even the coils that I said, the Mylene, I can't speak tonight, the Mirena or the J-Des or Kylena can actually stop the ovaries working. So again, induce, if you like, a chemical menopause. Now, if that's happening, we can actually give back hormones. And it sounds a bit unusual, and some of you might have listened to the podcast I did with my daughter Jess, which came out in October last year in 2023. And she is actually using a J-Des because she has awful migraines, so she can't have the combined oral contraceptive pill. She also has terrible PMS, and so she also has really heavy periods. So she had a Kylena to keep the lining of the womb thin, stop her having periods, which is wonderful for her. For me as her mother, it's great. She's got a really reliable contraception, but she was still getting this dip in her hormones, and also her migraines are very severe. So any changes of anything can trigger a migraine, including changing hormone levels. And although she had PMS, you know, fast forward another 15 years, 20 years when she becomes perimenopausal, those hormone swings will be a lot more, and I'm pretty much sure they would trigger migraines, because they do in a lot of women. So actually for her doctor has given her estrogen through the skin as a patch at the same dose. So she's replacing the estrogen that's been blocked by her J-Des with a very natural body identical estradiol through the skin as a patch, and that way her hormone levels aren't fluctuating, and that's been really good for her. And increasingly I've done that with quite a few women who want a reliable contraception, but they want the advantages of having hormones as well. And there's no reason that isn't safe at all, because all we're doing is topping up what her body would be producing. And so that's something that people might find quite difficult to access when doctors aren't thinking in that way. But actually, if we're switching off hormones, so say for example, I saw someone recently who's had an implant in, and she said since she's had the implant in, she's had night sweats, she's had joint pain, she's had muscle stiffness, she's had really dry itchy skin, she's had recurrent urinary tract infections, awful cystitis and vaginal dryness every time she wipes herself after going to the toilet. She said it's really uncomfortable. Now, she wants to have the implant in because she really needs reliable contraception. But actually, she could have some add-back estrogen as well. It's quite safe to do that. It's very individualised. And I think increasingly over the years, people will do that more and more actually, because women want their natural hormones, they want a good contraception, and they want to have this combination, if you like. Now, I said it right at the beginning when I started, HRT is not a contraception for most types, and I'm sort of hesitating there, and I'll explain why. So sometimes with HRT, the Mirena is part of the progestogen part of HRT. So if someone's got a Mirena in or wants to have a Mirena in because they've got heavy periods or they want a good contraception, absolutely bring it on. That can work really well. And there's no upper age limit for a Mirena. So some people just have them replaced regularly, and it can be part of the progestogen part of their HRT. And then we usually use estrogen through the skin as a patch or gel, or we give the testosterone as well, actually not all, as well. We can offer testosterone for those women who need it as a gel or a cream. And that's been quite well known for many years. Actually, increasingly, women still need progesterone. So even if you have Mirena coil, you can have the natural progesterone, Utrogestan, in addition to having Mirena, estradiol and testosterone for those women who need it and benefit from having the progesterone as well. Now, not everyone wants a coil, so then what do you do if you need contraception? Because I've already said HRT isn't licensed as a contraception. If you start HRT when you're perimenopausal, you're still having your own hormones, you might have some build-up of the lining of the womb, you might release an egg, then what are you going to do? And that's where we have to be really careful and look at the choices for that individual. Now, as many of you know, when we start HRT in the perimenopause, we give the progestogen part as a cyclical preparation. So it's taken for 2 out of 4 weeks. And ideally, we give the micronized progesterone, the body identical progesterone, for 2 out of 4 weeks. But quite quickly, usually after 3 to 6 months, I will change it so women have it continually. So they'll take usually one, so 100 milligrams Utrogestan every night, and then they don't have periods. Now, I've already said if you don't have periods, the lining of the womb is actually very thin. And if the lining of the womb is very thin, then it's very unlikely that a fertilized egg can implant. There's nothing that's 100% in medicine. And so the Utrogestan has never been tested as a contraceptive. And that's why it doesn't have the license. Now, the synthetic progestogens that we use as part of the progesterone-only pill, we know, I've already said, work by thinning the lining of the womb and probably often switching off the egg production as well and hormone production. But they've never been tested to see if they protect the lining of the womb of the proliferative effects of estrogen. So then, what do you do then? Well, actually, some women do take both. So I have got some patients who take a mini pill and then they take Utrogestan, the micronized progesterone as well. Some women go, do you know what, this is a bit of a faff, I'm going to have a coil in, a Mirena coil or a JDES to negate the need of having 2 different progestogens. I have some women who say, well, actually, I'm so happy on my HRT, I really want to have the natural body identical hormones, I have no side effects, I feel great, I know the risks are very low, because I've already said any risks with HRT are related to the synthetic progestogens. So I don't want to have synthetic progestogens, I'm going to have a coil, or I'm going to use barrier methods, which is quite fine if that's what they want to use. You can still have barrier methods. You can use condoms, for example. And then some women who I see have say, well, do you know what? I've been on the combination HRT for a year or 2 now. I've not had a period for a year or 2. So actually, I know it's not licensed as contraception, but it's likely to be okay, because if I'm not having periods, the lining of my womb is thin, it's very unlikely that I'm going to be able to implant a fertilized egg. So I have to have sex, obviously, to become pregnant. I have to have have an egg around, so I have to have ovulated, so I have to have sex at the right time. And even if that happens, it's very unlikely that the lining of the womb will be able to support this fertilised egg. Now that's all if, there's lots of uncertainties in that. But actually, I've said many times before, I feel I'm an advocate for the patients. For my patients, we do shared decision making and people can decide. Some women will say, do you know what, I'm going to take that small increased risk of becoming pregnant because I'm in my mid-40s. I took a long time to conceive my children, for example. I think it's very unlikely. And I've not had a period for a couple of years on the continuous Utrogestan. I'm going to take that risk that I know it's not licensed as a contraception, but actually I think in all probability it's very unlikely. Other people, if they're on a sequential preparation every 2 weeks on and 2 weeks off and they're having regular periods, then they shouldn't take that risk and they should be thinking about alternatives. And we have to remember actually, before I finish, that around 1 in 30 women under the age of 40 have an early menopause, they have premature ovarian insufficiency. A lot of these women would like to become pregnant. A lot of them being told they can't. But actually, if they have cyclical HRT, so 2 weeks on, 2 weeks off, the lining of the womb is building up in those first 2 weeks, they might be able to conceive. And we know actually when we have the natural hormones, our own ovaries aren't slogging out hormones in the same way, and they actually can be more beneficial and work better. So there is evidence that women with premature ovarian insufficiency who are on natural body identical hormones are more likely to conceive, depending obviously on their cause for their POI. And certainly in our clinic, we have had some pregnancies and women have been delighted. So actually we, as doctors, always think women don't want to get pregnant when they're on HRT, but some women do. And so if women do, then I would always recommend staying on cyclical HRT for as long as you want to get pregnant, because once you change to the continuous, it's less likely that you're going to get pregnant. If someone's going for IVF or they're trying to conceive and they're on HRT, of course it's very safe to continue with your HRT, because all we're doing is replacing what your body would otherwise naturally be producing. So that means if you're on progesterone in a cyclical way, if you're on estradiol through the skin as a patch or gel, and if you're on testosterone as a cream or gel, providing they're all in a physiological range and they're the right dose for you as an individual, then you should continue taking them even up to the point of trying to conceive. And if you're having IVF as well, you can still do that. If people do become pregnant, then often we will continue the HRT for the first 3 months. Certainly progesterone is very important. It can help keep a viable pregnancy. And many women who have had difficulty conceiving have low levels of progesterone. After about 3 months, the placenta will start to produce progesterone and support the fetus independently. So sometimes with women, we'll work closely with their obstetrician and continue their HRT as well, especially when it's the natural body identical hormones. The other thing to add about the synthetic hormones, like I said, they might not improve all the symptoms, and even if they do, we haven't got any studies, and I don't think we'll ever see any, that actually those hormones will have the same future health benefits as the body identical hormones do. So they're less likely to have the same effect on our bones, our heart, our brain. And that is important if you're thinking about taking hormones to improve your future health as well. I know some doctors give oral contraceptive, especially the combined oral contraceptive in the perimenopause, and some doctors in some countries do it. But actually, I don't usually do it unless someone really wants like combination oral contraceptive. Then I don't rush and do it for 2 reasons. Firstly, because it's hard to optimize the dose, because you're giving a fixed dose combination of a synthetic estrogen, synthetic progesterone without any testosterone. But also, as people are more perimenopausal, the dose often needs changing, and at some stage they're going to have to convert to body identical hormones anyway if they want the best type of HRT. So I think it's always better to start with something and start as you mean to go on rather than having to change. And there are risks with a contraception. There are risks of, like I say, clot, and that risk will increase the older we are, but also if we have any other risk factors for clots, such as being overweight, smoking, less mobile, or what have you. So actually, I just think it's better to have, if you've got a choice of something that's natural or something that's synthetic, then natural all the way, really. And that's really important when we're thinking about how it's going to work, like biochemically in our bodies. And when you take a step back and think about our natural hormones, like, it's not really the right thing to block them necessarily. Some women are fine on contraception, so I'm not here saying we shouldn't be taking them. I just think we should be aware of the potential risks and side effects and looking in a bigger picture. So that's a lot of information to take on board. I've gone over half an hour, but I realised that there was a lot there. For some of you, it might be new information. Some of you might know or have read Kate Muir's amazing book, Everything You Want to Know About Contraception But Too Afraid to Ask. Lots of science in there, lots of history actually. Some of it's very shocking when you read it. And on my story, I'll post some of the links for some of the resources that we've got on our Free Balance app, on our balance-menopause.com website, and obviously in my book as well. I've got some information that I've written about contraception, and I've done podcasts before about contraception as well. So thank you for all your questions, and have a great week. For those of you who have a bank holiday tomorrow, I hope you enjoy it. I hope the sun comes out, and just keep empowering yourself with knowledge so you can make the right decision and choices for you as an individual. So take care, and thanks very much.